This is a video in clinical medicine from the New England Journal of Medicine.
Emergency orotracheal intubation is indicated in any situation in which definitive control of the airway is needed. Specific indications include cardiac or respiratory arrest, failure to protect the airway from aspiration, inadequate oxygenation or ventilation, and impending or existing airway obstruction. Orotracheal intubation is also commonly performed as part of the care of the critically ill patient with multisystem disease or injuries, and to facilitate control of the airway during surgical procedures requiring general anesthesia. In emergent cases, such as cardiac arrest, airway management is of paramount importance, and there are very few contraindications to orotracheal intubation. Unstable cervical spine injury is not a contraindication, but intubation must be performed with strict inline stabilization of the cervical spine. If neuromuscular blocking agents or sedatives are used to facilitate intubation, the difficulty of intubation must be assessed and planned for before proceeding. This assessment is discussed in more detail in the accompanying written supplement. The presence of tumors, trauma, burns, edema, or infection of the pharyngeal or laryngeal soft tissues may distort airway anatomy, leading to difficult orotracheal intubation. When faced with a potentially difficult airway, consulting with an experienced intubator and preparing to use an alternative intubation technique are recommended. Begin by gathering the required equipment. You will need gloves, a protective face shield, and a working suction system, a laryngoscope with appropriate blade, an endotracheal tube with stylet, and a 10 milliliter syringe. You will also need a bag valve mask attached to oxygen, an oral or nasal airway, and tape or an endotracheal tube holder. There are two main types of laryngoscope blades, each available in various sizes. The tip of the Macintosh blade is curved. The Miller blade is straight, and each requires a slightly different technique. The choice of blade is based largely upon the experience and personal preference of the operator. A size 3 or 4 Macintosh or a size 2 or 3 Miller can be used in most adult patients. Endotracheal tubes are sized according to the internal diameter of the tube. 7.0, 7.5, or 8.0 millimeter tubes are appropriate for most adults. The tubes have a balloon on the distal end that, when inflated, creates a seal between the tube and the tracheal lumen and prevents air leaks and aspiration of gastric contents. You will also need a stethoscope and an end-tidal carbon dioxide detector to assess for proper placement of the endotracheal tube. Commonly used detectors change color in the presence of carbon dioxide. Before proceeding, be sure that all equipment is readily accessible and functioning. Inflate the cuff of the endotracheal tube to check for leaks. Insert the stylet into the endotracheal tube, making sure that the tip of the stylet does not extend beyond the end of the endotracheal tube. Be sure that the suction catheter is secured within easy reach. Obtain intravenous access and place the patient on a monitor if time and conditions permit. Assign an assistant to watch the monitor during the procedure and report any changes. Adjust the height of the bed so that the patient's head is level with the lower portion of your sternum. Unless contraindicated, place the patient into the sniffing position by placing a pillow or folded towel under the patient's occiput. This combination of flexion of the neck and extension of the head improves the alignment of the axes of the oral cavity, pharynx, and larynx, facilitating optimal visualization of the vocal cords. If the clinical situation allows, pre-oxygenate the patient with a non-rebreather mask or a bag valve mask with 100% oxygen for at least 3 minutes prior to the intubation.